So as you can see, I changed my title up significantly. Given that there's a lot of pioneers in this field in the room, I thought it'd be a good opportunity to kind of explore something new. And the crux of it, the genesis of it really, a recent visit I took to UPenn to visit Sunil's tremendous precision surgery program that he has there. And I had the opportunity to talk to a world-renowned head and neck surgeon who is both world-renowned for his accomplishments as well as his prickly personality. And when I'm showing him the data and kind of talking him over it, he says, so what? You can make the tumor glow. Where's the clinical benefit? What's the clinical utility? And it dawned on me that we're past the novelty of lighting up tumors. We're moving into what's the point? Surgeons think they can find the tumor no problem. And with the high clinical volume of today, we need to clearly define where the clinical benefit and utility lies. And I'm speaking in the context of exogenous agents for molecular imaging and targeting of cancer specifically. And so back to the topic, so how will this technology ultimately use to provide clinical benefit? This is something that my lab and others kind of sit around and talk about routinely. Where's the patient benefit? How are we going to advance this into clinical trial, into routine clinical use? And where is the reimbursement? Does it lie with CMS? Will it lie with the hospital? And so we kind of explore these topics. And so recently, because this is kind of a non-traditional technology and there isn't a true predicate, recently there was the World Molecular Imaging Society and the NCI sponsored a one-day workshop at the FDA. Well, it was at the NCI, but the FDA was invited in order to identify the regulatory pathways for clinical use. And because, once again, there isn't a true predicate here. And so I thought that I was very excited about this opportunity because I thought the FDA has no idea how this technology works. They hear fluorescence, they think fish, they don't know anything. So I think for me it was an opportunity because I think there was some misinterpretation about what fluorescence-guided surgery is. So I said, are we using the correct terminology? Fluorescence guidance infers that fluorescence is making the diagnosis. We don't want to ignore the years of surgical training and certainly the liability of the surgeon to actually be the ultimate one who makes the decision. It infers that the surgeon that the fluorescence is guiding the surgeon were to make the cuts. And I felt like a more true terminology would be fluorescence contrast enhanced surgery. We have contrast enhanced ultrasound. We have contrast enhanced MRI. If this is an